Good afternoon. So they just asked me, what is your talk called? How do you want it to be introduced? And I was so taken by Mark's discussion last night, basically about how things just don't change. And we're somewhere between a discussion where people say, oh, we're in this period of unprecedented disruption and transformation. And it's really not. Early in the 1900s really was considered to be the most technological change in the history of the planet. And what we're doing right now, we kind of tend to blow out of proportion about its real impact. And I think about how has home health stayed so insulated that it's managed to not change so much over time, despite everything that's going on. My introduction to home health in the 90s, I worked for Tom Scully when we were transitioning from HCIF to CMS. And I remember one of the first things that we did with home health was home health and electric scooters in Dade County, which was a complete crackdown of all these providers that really weren't providers. They had a PO box, but they didn't provide care. Well, we got pretty deep and we rooted out a lot of fraud and abuse, and it's been a success story since then for both the industry and CMS. But I also remember looking at a lot of numbers and models of care, clinical models. And who is providing care, let's say in the mid-90s, that's here today? How dramatically different is your model today and your company operating differently today? I don't know, your VPE drop when some kind of payment rule changed? But otherwise, what's really changed? Well, all this other stuff that's gotten in the way of the way that you get paid and the way your administrative rules operate. And today, I was asked to talk about conveners. So let's just start out with my changing perspective on conveners. So if any of you all have seen me speak before, conveners, middleman, unnecessary, just creates extra cost, doesn't provide any value. In fact, creates negative value because of the friction. A whole lot of other things that are quite unflattering. Then I would always get calls the next day, you hate us, how come you need to say these things? And I would make some trite excuse, because it's true, I would say. But now, just for the disclaimer, I'm on the board of directors for Tango, which was PHCN. Our company made an investment, so I have a point of view there. And we're acquired by Optum, LHC acquired by Optum just a few months ago. And so NaviHealth is one of our sister companies under the Optum Health umbrella. So that's the disclaimer. Now, I'm not going to say they're great, everybody else is bad. I'm going to try to lead you down a way of thinking that at the end will make us help make different decisions. So what does this thing mean, Steve Jobs moment? This is one of my favorite quotes. Basically, every time I'm in a conversation in this group think, it's with an MA plan and or a convener and providers, we always don't like what they're selling. We don't like how they do business. And they say, well, what do you want to do? What's the alternative? And we say, well, give us a 60-day episode and 14 visits. Well, isn't that what you do for your regular work in Medicare? Well, yeah, that's what we should do. That's the best thing ever. And it's really not. We've been intellectually and clinically lazy for the last 25 years, and we're doing basically the same thing that we've done over the last 25 years. And that's not what they want to buy. They are saying it very explicitly. Bring us something new. Bring us something that delivers even more value, that fits in our clinical model, that fits in this care continuum that we want to take risk across the whole gamut. And we say, okay, well, give us 13 visits in 60 days. And that just doesn't work. So when we think about this, we ask the conveners and we ask MA plans to give us something different, like more money, whatever, PDGM plus or minus this or that. That's not what they're interested in, and we don't have something else to ask. So while this quote is good, what I like to read is the whole quote, because at the end it says, our task is to read things that are not yet on the page. Guess what? The MA plans are not going to do your innovation. I'm including myself in this group. They're not going to do our innovation. They're not going to write the new care model for us and say, please do this instead because it's superior. To some extent, they'll just say, we're going to pay you this, and this is how many visits, and then we complain about it. I'm having this conversation with many people here today, like in the last 5 minutes. And so what can we do about it? But let's think about it. Because when I think about, since we have Run DMC, I'm just being a little nostalgic. Remember this movie? Sometimes we think that both MA and the conveners have a feeling about us. Like they're just not that into home health. And so they pay us appropriately. Like this is how you would be treated by somebody if you really like them and they didn't like you in middle school and you ask them for a dance and then they try to avoid you for the rest of the school year. But it really is not the case. And I don't think we're approaching our market and our opportunity the best that we can. So let me take you down a little kind of data road, and I want to paint a story, and then we'll come back to what to do about it. Now, the next couple slides I'm going to show is part of a body of work that in the industry, we brought some key people together to help us think through about our strategy on Capitol Hill and with CMS as we are shaping up for the next payment rule that is supposed to be, surprise, a cut. And so we've been many, many meetings. We've met with MedPAC, with CMS leadership several times now, and then all across Capitol Hill. If Bill Dombey were here, he and I have worked on these slides. We've gone all around Washington, D.C. together. I don't know if Dave is still here from this morning's panel. He'd be familiar with it as well. So these data come from the VRDC, the full Medicare claims data set, and Trella Health helped us do the analysis and produce this. I love this slide. This gives you a picture of every acute care hospitalization in Medicare fee-for-service that results in a post-acute transfer. So I call the bottom the Macaulay-Culkin group, which is the home alone. So they go from the hospital. That was a little funny, wasn't it? Thanks. They go home with no additional services. Let me tell you something that's really interesting here. In meetings, this is 4 or 5 years ago, with CareCentric, since we're on the convener page here, in meetings with them, when we were reviewing data together to look for value-creating opportunities, they say that they send home, at that time it was about 49% of all patients go home with no additional services post-acute, yet they made up 54% of the hospital readmissions. This is for all of us are in this market all over the country. So what does that mean? The people that are the least complex, least acute, don't want care, don't need it, thank you very much, are going to the hospital more often than the rest of the mix. Now, what you'll see from 2019 on, and this is really interesting, the share of patients that go to a SNF has been declining, the share of patients going to home health increasing. Now, there's a lot going on during this time. This little COVID thing where people didn't want to go to skilled nursing facilities, very, very challenged from every way imaginable, a lot of tragedy. And the home was a much safer place to be. But at the same time, if we pull these data back, there was a trend that's been moving, created by the ACO environment, that's really preferring lower costs of care settings. So basically, U.S. healthcare system relying more on home health, less on SNF for post-acute care. Very interesting. And despite all this cost cutting, fewer people are going home with no additional services. It's not just a cost thing. Interesting. Now, who all here works in home health? Okay, a lot. Basically, if you could get just Medicare fee-for-service patients, you would, right? You have a whole group of salespeople, and you give out PSLs to all your people. That's pumpkin spice lattes to try to make people warmed up to your company and remember you, so they send you referrals. Here's what's interesting. Let me see if we've got a laser pointer here. Maybe not. No laser. The bottom line is the percentage of referrals that go from the hospital discharge planning station to a home health provider that result in a rejection. So flip around. He's not that into you. It's the other way around. Now you're rejecting. In 2019, about a third of the calls that came in from Medicare fee-for-service, you said, I'd love to, but I can't. Sorry, call someone else. Now fast forward to last quarter, it's up to half. This is the same population that all of us are spending so much money on hiring and training good salespeople and making them empathetic and really smart about your product and going out and capturing trust, and we're still turning down nationally half of the referrals. Doesn't mean that by the third or fourth call, the patient ends up getting a home health provider, but this is quite disturbing. And that's fee for service. The next line up, they're autocorrelated. They vary the same. So we're up to 74% for MA patients now that are getting rejected by the first, second, third. We don't know how many phone calls because data is not collected that way. And then lastly, if you're a Medicaid patient and you're trying to get home health, or flip it the other side, you're in a hospital and you're trying to discharge your patient appropriately, you're having a very, very hard time. So we wanted to know whose problem is this? Because we go to Capitol Hill, we talk about how this is really crippling patients' ability to have an appropriate discharge to go home. This is an access problem for Medicare beneficiaries to get the care that they need. But when I spend time on a couple leadership boards at the American Hospital Association, boy, those guys are hurting badly from a financial point of view. These are all public data you can look up, but also from trying to balance their staff and trying to discharge their patients in a timely manner, especially those that are part of health systems providing home health. What we see is an increase in length of stay for hospital for patients that are being discharged to home health. It is about 10% longer now than it was we'll call it PDGM and pandemic, because that's when our rate cuts really started. And if you look, now there's starting to be some daylight between length of stay for a patient on Medicare fee-for-service and Medicare Advantage. This is not what hospital CEOs, CFOs, DONs want to see. They want to see quick discharge, not take up more of their staff's time, and they also want another revenue patient in that same bed. So again, where is the demand curve? Is it from us or from the payers that need us? Obviously, I'm building this story here. We asked the next question. We said, all right, if there's really a big access issue, then clearly everybody's not getting care. Otherwise, let's just send a cookie cake out to all the discharge planners because we feel bad for them, but they'll have to get over it. But it's not that simple. We asked, there's two different things going on. I just tried to get it in one chart. We said, how many patients are being referred to home health that don't get it? The answer is right here, but what we know in the market is somewhere around 15% is what a referred patient that is fully qualified that says, you know what, I don't want a stranger in my home, my house is a wreck, I don't want somebody in making me do stuff that I don't want to do, therapy or something. My grandmother was like that. She didn't want somebody to make her exercise or see her hair when it wasn't done. And for a variety of reasons, there's about 15%. But now what we're seeing here is more than 30% of patients that are being referred to home health are not getting it. That is quite troubling. Now, if you're in the administration today and you think, well, health equity is a big thing, well, you better think again, because a lot of patients are being denied care in their home because the American healthcare system is set up in a way to just say it's okay to have access problems. And in fact, maybe we should cut rates a little more because we think maybe there should be a little bit more access problems. Obviously, that's not what they want. That's the point we're trying to make. Then we asked, but is there really any difference in the outcome for patients that are qualified and referred to home health and then don't get it? And boy, we held our breath because if it turned out there was no difference, then it'd be a real problem. But that's where the headline comes. 23% higher readmission rates for those that were qualified, referred to home health, and then didn't get it. And these come out of EMR data. So these are highly reliable and valid sources of knowing who's supposed to go to home health and who doesn't go. This is really quite convincing. And when CMS saw this for the first time, they were taken aback because we make a don't cut off your nose to spite your face discussion about, do you really want to cut rates a little bit more? And it's going to cost you a lot more in other parts of the Medicare trust fund. So what's the reality? Is it still, he's really not into you? Or is it another cultural icon? Or is it really everybody wants you? And come on, guys. Thank you. I had to look for this. I knew this was a song, and I couldn't remember it was Billy Squire that sings it. And it's a good song, too, like from my roller skating days. I never had hair that long, though. So let's discuss this. The way that we go into negotiations is interesting. I was thinking about this when Bill was on the stage. He's such a good friend and mentor of mine. I've learned so much both about home health, but also about the way to interact with the Hill and the administration, even though I come from both of those sides. He's a maestro at it. And when you think about it, back in the old days when we were like, 91% Medicare in your payer mix, he was your chief negotiator. When you said, I need a good contract, I need to get paid well, let's send our, VP of contract? No, it's Bill Dombey that is negotiating rates for your whole home health platform back in the day. And then you took a little bit of this Medicare Advantage because, you had to just to get the other referrals in addition to your PSLs, pumpkin spice lattes. But that is not the case today, where if you're in a payer mix, 68%, 75, 50%, depending on what market you are, Bill's going to do his job for sure, but that's not the only person that's negotiating rates for you. You really need to be negotiating rates with multiple plans in multiple parts of the country, and maybe you're not that good at it because you just started, and you can't even get the plan to return your phone call. You can't even get whoever that right person is. And I'm going to kind of walk you through some of this because why does it matter? Why are we even talking about conveners? I've been doing a light sample. About half of the home health operators I'm talking to here say, I don't even deal with them. They're just not in my area. It doesn't matter to me. I think I know what they are. And then some I talk to, I won't say who, sitting in the front table, just really is not having a good experience. And so we're really bifurcated in the degree to which you're taking patients from plans that use conveners to deal with it. But we don't have a choice. More than half of the Medicare program today is in a Medicare Advantage program. Staggering. I just look back in the old days. This chart could go further back into the 90s. I was telling you the story, I was at HCIF and CMS when the Medicare Plus Choice program was passed in the 1997 BBA, and we wrote rules for it in 98 and 99. That was the predecessor to Medicare Advantage. And we thought back in the day when we were at 9, 10, 11%, like, one day we might hit 15% of the Medicare program. And all the people that wanted to sort of privatize Medicare would high five and just think so much progress is being made. Later in the Bush administration, when I was running parts of Medicaid, we watched this go more and more and more, and we were at 15%. We thought we were doing a good job, and we were incenting rates to try to encourage more people to use these health plans to get additional benefits and get case management and have chronic condition management in their in programs for them. And I don't think anybody really was able to see we were going to hit 50% so quickly. And it's one of the few things. There's kind of the VA, there's some patriotism things on Capitol Hill that both sides agree on, but you wouldn't believe it. Medicare Advantage is such a popular topic. And in one day, I was in a meeting with Ron Wyden, and he couldn't stop just waxing so beautifully about Medicare Advantage, how great it is. And I was with Mitch McConnell later in the day saying Medicare Advantage is a critical part of the American healthcare system. We have to do more for it. I thought, this is crazy that they both love it. I don't know what to do. But does it really matter? Because we're talking about home health. And this is part of the problem. It's not that somebody's out to get us. If they did, they don't know where to look. We talk about let's negotiate with health plans. Well, how high on the priority list is home health? I put up some statistics that came out of a CMS publication. Back in 2010, home health made up 4% of the Medicare spend. And managed care is another part, so there'll be some portion of managed care that went to home health as well. So even if 4% of 22%, we were 5.4% back then. 2019, CMS not that fast with updating their data. So for basically 66% of the program spend, We make up 2% of it. If you look at national healthcare expenditures, good data done by the actuary, this huge trillions of dollars of spending, home health makes up between 2 and 3%. Nationally, everything we spend, home health 2 to 3%. Now, what are they focused on? Inpatient hospitalizations, 31. Physician services, 20. Drugs, 9. There's 60% of the spend in 3 categories. Guess what? Their most talented people are working on that for sure. Where does the person that's working on home health fall within these plans? They're very talented, but they tend to be super overworked because they get like all this other stuff, SNF, home health, hospice, DME, other. I don't even know what other includes, but they're in charge of that too. And so when you want to make an appointment and you want to go see them to say, hey, we want better rates for home health. Okay, good. What are you going to do for it? What do you want? No, that goes back to the Steve Jobs moment. What are you selling? Do you know? Are you just going to say PDGM minus 10%? Why? I don't know. Are you going to say whatever we do, number of visits for PDGM minus 2? I don't know. Would you have a special app? I don't know. What's the point we're trying to make? We're trying to deliver value. They're asking for value. Yet we have not evolved what our offer is or what our value proposition is under a value-based model. Here's what we know, though. Who here participated in the Medicare Home Health Value-Based Purchasing Program from CMMI? Probably more of you did and maybe don't know it. Ran the model in 7 states. Thank you. Actually, it wasn't that funny, though. You really should know if you are doing the program. But here's what's interesting. So CMS ran it in 7 states. They did it for several years. They stopped. They looked at the data. Overall, CMMI ran 54 programs. Only 5 of them saved money. Home health, this program saved the second highest of all of this 10-year experience with CMMI. And what's interesting is you could see the numbers in the second bar. Huge reduction in inpatient hospitalization, huge reduction in the use of skilled nursing. A little bit more on the use of emergency department. And there's a couple reasons why, we suppose. But in the evaluations, they asked the large carriers, I'm sure we were asked at that time, what did you do differently in these pilot states? And more or less it was, nothing. Didn't know what was going on there, maybe. It was just companies that had high quality, good platforms. They ran home health really well. They saved this money. Now, interestingly, if you're a doctor, you're in the ACO program. When you have savings, you split the savings and you get a bunch of money. For some reason, home health, they never thought that we would be interested in getting some of the savings. So this is something that, when you think about it, the Medicare Trust Fund gets all of these dollars, not us. So what causes this variation? Well, there is huge variation in quality. Who's got stars 4 and above here? It gets the most hands I've seen. Because it's important. We get it. It's palpable. You can see it. It's measured all the time. It's reported back. We look at overall cost of care for all of our payers, Medicare included in the ACO program. Recertifications varies like crazy. If you look at this curve, it's really spread out. You look at VPE, whether it's for the episode or for the entire admission. These numbers vary dramatically by provider, not just market, but within markets, great deal of variation. Some providers, especially pre-PDGM, they love to do therapy. They didn't like to do wound care. PDGM adjusted for that by changing the payment, I think in a very laudable way. Good job, CMS. But there's still some providers that like to focus in on some and not all areas. We know that some just don't have the capacity to take many patients. They're not sophisticated in load balancing ways or ways to surge up and down labor. We know that from technology in a way to be able to do two-way data exchange, not every provider is there at the highest level. And in our area, it's we're not as advanced as we certainly could be. In the next presentation, you're going to see just how far technology is going, and we're not part of it. And really, the ability to take risk. And it doesn't mean truly the ability, it's understanding, it's working it in the business model, it's whether you're owned by a family, by public or a PE, are you able to take risk and able to think about how your performance is looking forward? So what does that mean? We just saw 50% of the nation's Medicare beneficiaries are in MA. The amount spent on home health is small, not a priority for those that are doing contracting. Yet we're seeing plans turn to the term that's used as conveners to do, some will say their dirty work. What do you want to do? Deny patients care? Create friction to get in? Are you going to price arbitrage so you have an MA plan that pays already we'll say an uninteresting rate, and then you're going to put a whole company that has to make profit in between to take money out, and then what's left after that to pay the providers that's supposed to be excited and willing to provide care? So let's talk about why that model is wrong. And so I'm not here to defend any of those that I've called middlemen and not adding any value to the equation. I think a great deal of that is because we've been willing to be taken advantage of. We've not done anything in response to, yet we complain about it. I feel like conferences are really just group therapy sessions, and I'm the therapy leader when I complain about conveners, and then every drink is bought for me at the bar afterwards. I don't want that kind of charity. We really have to think about what would we do if you were the CEO of an enabler, knowing the value that we possess, yet has not been expressed properly, both from an analytics and a show you my value proposition, and not been expressed in the amount of horsepower that is not opened up through our innovation yet side. What would we do differently? And so I think about it. There are going to be some conveners that are going to be hired by MA plans that are going to price arbitrage and utilization manage, period. They're going to charge a couple cents on the dollar, take delegated risk. They're going to be stovepipe to home health only and not unlock the huge value of having a decreasing SNF spend because you're bringing more people home. That's the right way. But there are going to be those that are going to do it the wrong way. Just put them to the side for a second. Let's talk about the rise of the enabler. An enabler will want to only contract under value-based terms. Now, the slide I showed you before about the great deal of variation was not for no reason. It was because there are enough home health providers that are high quality, high integrity, high discipline, have a huge heart. Their DNA is about caring and clinical, and they're going to do very well. And that, by the way, is different than the bottom 10, the bottom 25% of providers. Yet, we all get paid the same. And that's really not how it ought to be. If you're in a market with 3 hospitals, and one, people die all the time, half of it's closed, they get immediate jeopardy all the time, NCQA won't certify them, should they fail Joint Commission? Why would they get paid next door to the best hospital in the country, whether for cancer care or birth outcomes or pick of a diagnosis? They don't. Insurers will kick those hospitals out of their network. For us, in our country, we have 11,000 something licensed home health providers. We have over 9,000 that dropped a claim last year. I bet if you added up all the agencies contained in this room, maybe we're 2,000, 2,500. My suspicion is that there are ways for us to work together with an enabler interested in taking the value that we can provide and compensate us fairly for that. We have to make a clearly articulated offer in that. We haven't done it yet. These are the things that we need to do. Again, be able to take a value-based relationship. Would you take, say, 85, 90% of PDGM with an opportunity to get to 105 or 110? I'd take it all day long. I would say, tell me more. You've got to be truly able to exchange information back and forth. If you can't both give and take information quickly and be able to react to it, you're probably not that sophisticated a provider. You need to be able to be part of an exclusive set of preferred providers. And why we don't have those today, I don't know. We should have been doing this in the 80s and the 90s. Yet the great providers are along with the terrible providers, and we get paid the same, and we get referred to as much as you can do, whether pumpkin spice lattes or billboards or some other way. But very rarely is it based on your hospital readmission rate or your stars. I want gold carding because I don't want to play with the fuss up front. When I get a referral that's validated by an enabler, I want to start providing care. I don't want to spend another 6 hours of rev cycle just to get that validated, to be assured that I'm going to get paid at the end. I want to get paid in a real way, whether it's call it a bundle, an episode, or a case rate, but I want to get paid the right way, not mother may I every 2 or 3 visits. And lastly, it really has to be based on outcomes. You have to be willing to commit that you will manage and lower rehospitalizations. You will have programs that will help patients be able to go home quicker from the hospital. You will make sure that where possible you can bring patients home instead of go to a skilled nursing facility. And then you have to manage your patient satisfaction, your engagement levels, ways that we're not measuring today. Those are the pieces that we're not doing. I think if we do this together, the right set of providers to make the right offer to the right enabler, we could really change the way that we're doing business with MA plans that way. So I'm around. Happy to share this deck. I'm out of time. I'd be really anxious to hear what your points of view and what you think about this. Thank you.
Thank you so much, Bruce.